Welcome to the deep dive. Today, we're taking on a symptom that sounds pretty straightforward, right? Double vision or diplopia.
Hmm.
But it escalates quickly into this really structured, almost satisfying diagnostic puzzle. Involves neurology, ophthalmology.
Absolutely. It's one of those symptoms where the path you take matters immensely.
And our sources lay out this fantastic roadmap, really, for systematically figuring out why someone is seeing double.
Yeah, and that's the core challenge, isn't it? Diplopia just means seeing two images of one thing. Simple description.
But the why is complex.
Exactly. As soon as a patient says that, you've got this fundamental split. Is it structural, something wrong inside the eyeball?
Like a mechanical issue in the eye itself.
Right. Or is it neurological? The eyes themselves are fine, maybe, but they can't align properly. They're not moving together as a team.
Okay, so that structural versus neurological divide, that's kind of the mission for you, the listener, today. We're going to map out the exact steps, the questions, the exams to pinpoint the cause.
And it all starts with one basic classification, determined by a really simple test.
Just covering one eye.
Yeah, just ask the patient to cover one eye. If the double vision is still there, even with one eye closed,
Then the problem must be in the open eye.
that's monocular diplopia. But if the doubling only happens when both eyes are open and it goes away when you cover either eye,
Then it's an alignment issue. Both eyes need to be involved.
and that's binocular diplopia, that immediately tells you, okay, we're looking at an alignment or movement problem, likely neurological.
Okay, let's dig into that first scenario then. Monocular diplopia. So I close my left eye, I'm looking with my right, and I still see double.
Yep. The problem is definitively inside that open right eye. It's not about alignment anymore.
It had to be something physical, blocking or maybe distorting the light coming into that one eye.
Exactly. So when the symptoms stick around with one eye closed, you test the eye's structure. And the critical first step is, surprisingly simple, the pinhole exam.
The one with the little card with tiny holes?
That's the one. You have the patient read an eye chart looking through one of those small pinholes. What this does, essentially, is filter the light rays.
And that helps isolate where the problem is.
It does. By cleaning up the incoming light, it tells you if the issue is mainly about focusing or something else.
Okay, so what if, looking through that pinhole, what if it doesn't help? Vision is still blurry or doubled.
Right. If filtering the light doesn't improve things, it suggests the problem isn't just like optical scattering at the front of the eye, it's deeper.
Right, exactly.
It points towards the retina, specifically the central processing area, the macula. You're thinking about potentially serious things then.
Like what?
Macular edema, maybe from diabetic retinopathy or age-related macular degeneration, AMD. Even inflammatory stuff like uveitis can affect the macula.
Okay, but what if the pinhole does work? The vision clears up significantly.
If it does improve, that tells you the problem is optical. It's something the pinhole can correct by focusing the light better.
So the issue is somewhere in the front part of the eye's focusing system, like the lens or cornea.
Precisely. So pinhole helps. Next step. Check the lens. You do a fundoscopic exam. If you see cloudiness and opacity.
That sounds like a cataract.
Straightforward diagnosis. Cataract. And the sources highlight the usual risk factors. Getting older, lots of sun exposure, smoking, diabetes, long-term steroid use. Things like that.
Makes sense. But what if the lens looks perfectly clear on exam, yet the pinhole still helped?
Good question. Lens is clear, pinhole helps. It means the light is being bent incorrectly, but not because of a cloudy lens or retinal issue.
So it's not disease, just shape.
Exactly. It's a refractive error. The eye's shape isn't focusing light perfectly on the retina. This covers, hyperopia, being farsighted.
Myopia, nearsightedness.
Yep. And astigmatism, where the cornea isn't perfectly round. That irregular curve scatters light, and that covers the bases for monocular diplopia.
Right, so we've ruled out problems inside the eye itself. Now, if the double vision disappears when the patient covers either eye,
The whole game changes. Now we know it's binocular. The eyes aren't aligning.
and that points us towards the nerves controlling eye movements.
Directly. We're thinking about the three main players, cranial nerve the third, oculomotor, cranial nerve 3, trochlear, and cranial nerve 6, abducens.
Okay, so how do we start sorting those out? Is there a first step?
There is. You ask the patient about the orientation of the double image. Are they seeing one image on top of the other? Vertical diplopia.
Or are they side by side? Horizontal diplopia.
Exactly. That orientation is the first big clue. #, A, vertical diplopia, CN IV palsy.
Let's start with vertical. One image above the other.
If it's vertical diplopia, your prime suspect is cranial nerve 4, the trochlear nerve.
Why specifically CNIV for vertical?
Because CNIV is unique. It only controls one muscle, the superior oblique. And that muscle's main jobs include depressing the eye, pulling it down, and entorting it, kind of rotating it inwards.
Okay, so that muscle isn't working right because the nerve is damaged.
You get vertical misalignment.
Okay, and I remember reading something interesting about CNIV palsy patients often do something specific with their head.
Yes, it's a classic finding. They'll often present with a head tilt away from the side of the affected eye.
Lie away.
They're subconsciously using their head position to compensate, to use the other healthy muscles to try and bring those two vertical images back together. It helps reduce the doubling.
Clever. And how do you figure out why the nerve isn't working?
History is key here. Did this start suddenly after, say, hitting their head? That suggests a traumatic palsy. Or has the patient always had a very slight head tilt, maybe since childhood, that's only now becoming noticeable or causing symptoms? That points towards a decompensated congenital palsy. They were born with a mild weakness that the brain could overcome until now. #B, horizontal diplopia, CN third and C's palsies.
All right, let's shift gears to horizontal diplopia. Images side by side. Now we're thinking CN the third or CN the right.
Correct. And if you suspect CN the third, the oculomotor nerve, there's something you need to check immediately.
The pupil.
Exactly. Check the pupil. Because CN third does so much more than just move the eye side to side.
Remind us what all CN third controls.
Oh, it's the powerhouse. It handles 4 of the 6 main eye muscles, the ones that move the eye up, down, and in. Plus, it controls the muscle that lifts the eyelid, the levator palpebrae superioris.
So that's why you get a droopy eyelid, ptosis with CN third problems.
Yep. And crucially, it also carries the parasympathetic fibers that tell the pupil to constrict.
Okay, so if the entire nerve is knocked out, what does the eye look like? Where does it sit at rest?
Well, because the muscles pulling the eye out, CNVI, and slightly down and in, CNIV, are still working unopposed, the eye typically ends up in a characteristic down and out position.
Down and out, plus the macuntosis.
Right. And patients might actually describe the double vision as oblique or diagonal, not purely horizontal, because so many movements are affected. It often gets worse when they try to look at something close up because adducting the eye, moving it inward, is impaired.
Now, back to the pupil. This is a really important distinction, isn't it? Pupil spared versus pupil involved.
Hugely important. High stakes, really. If the pupil is spared, meaning it looks normal, reacts normally to light.
That sounds like good news? Maybe.
It points towards a specific cause. Ischemic mononeuropathy. Basically, not enough blood flow to the nerve, usually from microvascular damage. Think diabetes, hypertension.
But why would lack of blood flow spare the pupil function?
It's anatomy. The parasympathetic fibers controlling the pupil run along the outside surface of the nerve bundle. The motor fibers are deeper inside.
Okay.
So an ischemic process affecting the inner core blood supply might damage the motor fibers, but spare those superficial pupil fibers.
Got it. So conversely, if the pupil's involved, if it's dilated, sluggish, doesn't react well.
That's much more alarming. A dilated pupil suggests the nerve isn't just ischemic, it's being physically compressed from the outside.
And what's the big worry there?
The classic critical cause is an aneurysm, usually on the posterior communicating artery, the PCM. It presses on the nerve from the outside, hitting those superficial pupil fibers first or simultaneously.
And that's an emergency.
Absolutely. It requires immediate neurovascular imaging, like an angiography, to find and potentially treat that aneurysm.
Okay, that covers CN through thoroughly. What about the other cause of horizontal diplopia? CN the eyes. The abducens nerve.
CNVIs is much simpler in function. It has just one job: innervate the lateral rectus muscle.
The one that pulls the eye outwards, abduction.
Exactly. So a CNVI palsy means the patient can't fully move their eye outward, away from the nose. The double vision gets worse when they try to look far away into the distance.
And what usually causes a single CNVI palsy?
Like with pupil-sparing CNVIs, unilateral CNVI's palsy is often ischemic mononeuropathy, especially in older adults with vascular risk factors.
But what if both eyes have impaired abduction? Bilateral CNVI's palsy.
That's a major red flag for increased intracranial pressure, ICP.
By both sides.
CNVIs has a very long winding path through the skull, making it vulnerable to generalized pressure increases. Seeing it affected on both sides strongly suggests something is raising pressure inside the head.
So immediate head imaging.
Immediate head imaging, yes. And check the back of the eye with a fundoscope. You might see papilledema, a swelling of the optic nerve head, which is another sign of high ICP.
Okay, one more specific alignment issue before we move to systemic causes. Internuclear ophthalmoplegia, INO. This sounds complicated.
It sounds tricky, but the finding is quite specific. It's not about one nerve being out, it's a communication breakdown between the nerves.
Communication breakdown.
Yeah. Specifically, it's a lesion in a pathway called the medial longitudinal fasciculus, the MLF. Think of it as a critical data cable in the brainstem, connecting the nuclei of CN-ther and CN-th on opposite sides.
What does that connection normally do?
It ensures that when you look to, say, your right eye abducts, CNDI, and your left eye abducts, CN-th,
Right.
smoothly and simultaneously. It coordinates that gaze.
So if the MLF cable is cut,
You get INO. The classic sign is, when the patient tries to look sideways, the eye that's supposed to abduct to turn inward fails or lags significantly.
and the other eye.
The other eye, the one that successfully abducts, looks outward, often shows nystagmus, these rhythmic, jerky movements.
Impaired deduction in one eye, nystagmus in the other, during side gaze. That's INO.
That's the signature. And the cause often depends on age. In younger patients, you think demyelinating disease, like multiple sclerosis.
And older patients.
More likely a small stroke in the brainstem affecting the MLF. Diagnosis usually needs a brain MRI to confirm the lesion.
Okay, we've covered monocular and then binocular based on vertical or horizontal patterns linked to specific nerves or the MLF. But what if it's messier? What if the patient has double vision that's both vertical and horizontal, kind of all over the place?
Right, when the diplopia is complex like that, not fitting neatly into one nerve's territory, it often pushes us to think beyond isolated nerve problems. We start looking for more systemic issues.
And the first step there is to look at the eyes themselves, externally.
Yeah, you need to assess for other external ocular findings. Are the eyes bulging out? That's proptosis. Is there swelling of the conjunctive ecchymosis, redness, injection, swelling around the eye socket, periorbital edema, #tag A, with external ocular findings?
Okay, so let's say we see those external signs, bulging, swelling, redness. What's the next question?
The next crucial branch point is, does the patient also have any facial numbness or altered sensation on the same side?
Why is numbness important here?
Because if you have these eye movement problems plus facial numbness, suggesting the trigeminal nerve, CNV, is also involved.
Multiple cranial nerves affected together.
Exactly, especially nerves 3, 4, V, and 6. That combination strongly points to a problem in a specific location, the cavernous sinus.
That's that space near the pituitary gland where all those nerves run close together.
Precisely. So if multiple nerves passing through there are malfunctioning, you suspect a lesion in the sinus, maybe a thrombus, a blood clot, an infection, or even a tumor pressing on everything. It becomes an anatomical diagnosis, cavernous sinus syndrome.
Got it. But what if they do have the bulging eyes, the lid retraction, maybe the redness, but no facial numbness? CNV seems fine.
If you have those prominent external eye signs, proptosis, lid issues, injection, but normal facial sensation, you pivot strongly towards thyroid-associated ophthalmopathy, TAO.
Related to Graves' disease.
Often, yes. It's an autoimmune process where inflammation and swelling affect the tissues around the eye, especially the extraocular muscles themselves, causing misalignment and those physical changes.
Are there other signs to look for?
Definitely look for systemic signs of thyroid disease, a goiter in the neck, or pretibial myxedema, that characteristic kind of thickened, discolored skin on the shins.
And how do you confirm TAO?
You'd order blood tests for specific antibodies like TSH, receptor antibodies, check thyroid function tests. And imaging, a CT or MRI of the orbits will typically show those extraocular muscles looking enlarged and swollen. #BB. Without external ocular findings, focus on time course.
Okay, what if the patient has complex double vision vertical and horizontal elements, but externally, the eyes look totally normal? No bulging, no swelling, no redness.
Right. If there are no external signs, then the time course of the symptoms becomes really critical.
How so?
Well, first scenario, has this complex diplopia been getting progressively worse, not over years, but fairly rapidly, like over days to worse?
Okay, rapid worsening. What does that suggest?
That kind of subacute progression should raise suspicion for the Miller-Fisher variant of Guillain-Barré syndrome.
Miller-Fisher. I know Guillain-Barré affects peripheral nerves. How does this variant present?
It has a classic triad. First, the ophthalmoplegia, the eye muscle weakness causing the diplopia. Second, ataxia problems with coordination and balance. And third, areflexia, loss of reflexes.
Eye problems, coordination issues, loss of reflexes. How's it confirmed?
Usually with a lumbar puncture, a spinal tap. You're looking for a specific pattern in the cerebrospinal fluid, CSF. albuminocytologic dissociation. High protein levels, but a normal white blood cell count. That's characteristic.
Okay, that's the rapidly progressive picture. What about the other end of the spectrum? What if the double vision comes and goes, fluctuates? Maybe it's worse after they've been reading or driving for a while, or just worse at the end of the day.
That pattern, intermittent, variable, worse with fatigue or sustained use, that is the absolute hallmark of myasthenia gravis, MG.
The neuromuscular junction disease.
Exactly. It's autoimmune. The body attacks receptors at the junction where nerves talk to muscles, leading to muscle weakness that gets worse with activity and improves with rest.
And the eye muscles are particularly susceptible.
Very often, the first muscle's affected. Many patients present only with ocular symptoms like diplopia and ptosis initially, before any generalized weakness develops.
So how do you nail down the MG diagnosis?
Primarily through blood tests looking for specific antibodies. Antibodies against the acetylcholine receptor are the most common, but you also test for others like MuSK or LRK4 antibodies if the first test is negative, but suspicion remains high. #tag outro.
Wow. Okay, that is quite the journey. We literally started with just seeing double.
Mm-hmm.
And followed this incredibly logical pathway, using things like a simple pinhole test, checking pupil responses, looking at head tilts.
All the way through to considering brainstem lesions, aneurysms, systemic autoimmune diseases.
It really highlights how structured the diagnostic process can be if you follow the anatomy and physiology.
It really does. And what's hopefully clear now is that fundamental split we started with. You, the listener, can now better differentiate between a problem of the eye's physical structure,
Like the lens or the retina.
and a problem of coordination involving the cranial nerves, the brainstem pathways like the MLF, or the neuromuscular junction itself. They present differently and require totally different workups.
So thinking about those nerve issues, the cranial neuropathies,
Oh.
what's a final thought for clinicians encountering these cases?
I think it's crucial to remember that when you trace diplopia back to a cranial nerve problem, CN3 or 5 or 6, the injury itself could be anywhere along that nerve's path.
You mean not just compression or ischemia affecting the nerve fiber itself?
Right. It could be damage to the axon, sure, but it could also be damage to the nerve's control center, its nucleus, which sits deep inside the brainstem.
So things happening in the brainstem could cause these eye movement issues.
Absolutely. Any lesion within the brainstem, whether it's a stroke, a patch of demyelination from MS, or even a tumor growing there, can potentially damage these cranial nerve nuclei,
And that would manifest as diplopia.
profoundly impacting something as intricate as binocular vision. So diplopia isn't just an eye symptom. It's often a critical neurological signpost. That complexity makes it vital to investigate thoroughly.
An incredibly interconnected system indeed. Thank you for walking us through that dense but really, really fascinating deep dive into diplopia diagnostics.
My pleasure.
If you want to keep exploring this interplay between vision and the brain, understanding those cranial nerves is definitely key. We'll see you for the next deep dive.